Namaste and hello to everyone. I am Dr. Sameer Dulal, Hybrid International Emergency Medicine Trainee and Associate Member of Royal College of Emergency Medicine, UK. I am currently practicing emergency medicine at Chittor Medical College and Teaching Hospital, Nepal. Before beginning, I would like to express my gratitude towards CMCIRC, Humate International, WAML, and DBTH UK for providing such an opportunity to make a video presentation regarding my research. I now welcome you to my presentation. So let's start with the title of my project. Comparison of shock index and modified shock index in predicting hemodynamic instability and associated outcomes in suspected hypovolemic shock at emergency department of Chittor Medical College. Shock, whatever the etiology, is a global burden. It is a state of systemic hypoperfusion with inadequate blood supply to the tissues. It impairs the microcirculation and macrocirculation and therefore affects many organ systems. Shock is extraordinarily important because it is generally a final common pathway before death. Most serious diseases are capable of causing shock. Hypovolemic shock is characterized by reduction of intravascular volume and a subsequent reduction in preload. Left untreated, shock will progress to multi-organ failure and even death. However, shock is often reversible, thereby avoiding death. Shock index and modified shock index are bedside assessment tool. They are very simple and effective means of gauging the degree of hypovolemia in hemorrhagic and infectious shock states. Being an emergency medicine resident, we have to deal with difficult decisions when managing unstable patient. Thus, it is fundamental to find useful and consistent tool that will help in trials regarding hemodynamic instability and also equally important to provide critical information about outcome. Now, I would like to talk about Mr. Alex, a 24 years old male who presented to emergency department after road traffic accident. Upon ABCDE assessment, he is found to be in shock state, most probably hypovolemic shock with heart rate of 110 per minute, blood pressure 80 by 50 mm of mercury with mean arterial pressure of 60 mm of mercury. His periphery was cool and clammy and the central and peripheral pulse were feeble. His shock index and modified shock index are calculated to be 1.3 and 1.8 respectively, which are significantly high and reflects poor outcome. Later, ABG revealed severe acidosis and lab revealed coagulopathy. Lethal triad of trauma was diagnosed and next day patient died at SICU. Thus, in this case, shock index and modified shock index helped me in risk stratification, counseling, disposition and mortality prediction. I now show you the process mapping. 24 years old female arrives at ED with complaint of abdominal pain and she is shifted to LO area. Junior doctor assesses her and thought of peptic ulcer disease. Her blood pressure was 90 by 60 with pulse rate of 102 per minute. Shock index and modified shock index was not calculated and re-evaluation of the vitals was done late. Her UPT status was not recognized and later her clinical condition deteriorates. USC abdomen and pelvis was performed after positive urine pregnancy test and revealed free fluid in the peritoneum. A diagnosis of rupture ectopic was made and case was shifted to operation theatre. In this way, process mapping helped me in identification of key problems. My research is a purposive observational quantitative study. It is a quality improvement project. I will use the element of quality improvement, stakeholder analysis, fishbone analysis in my study. Now I will present you the literature review. Coates et al. 2019 concluded that elevated shock index greater than 0.7 has been shown to correlate with increased likelihood of inpatient admission, mortality and other outcomes like massive transfusion protocol activated in trauma. There is another literature review done in 2017 by Alge Torseros Almanza et al. Which concluded shock index and modified shock index are good predictors of massive bleeding and could be easily incorporated to the initial workup of patient with severe trauma. This is by Gantt chart for 4 years duration. The writing has already begun and I'll focus on data collection, data analysis. When I return back, clearance and ethical approval will be taken from the CMCIRC. I will use written consent form in my research, maintaining the confidentiality of the patient, and data will be collected using the preform performer as shown here. The data will be analyzed using the software SPSS version 20 and relevant tables, charts, bar diagram will be displayed, and I will look forward to publish my research using the SQUARE guidelines. Thank you for being with me. Namaste.